Thank you, Dr. Weiss. Good afternoon, everyone. We have two speakers today. I'll introduce them both now. I'm proud to introduce our first speaker, Dr. Joshua Laban. He's newly appointed Assistant Professor of Clinical Medicine and an attending physician in the Division of Hospital Medicine here at the University of Miami. Dr. Laban was born in the U.S. Virgin Islands. He competed as an Olympic swimmer and was flag bearer for the Virgin Islands at the 2008 Olympic Games in Beijing. He graduated from Meharry Medical College in Nashville, Tennessee, and he trained here in internal medicine at the University of Miami and Jackson Memorial Hospital, where I was proud to call him my co-resident. And he will speak to us today about updates in hospital medicine. Following him, our second speaker, Dr. Alex Velasquez, Assistant Professor in the Division of Cardiology, who specializes in electrophysiology. Dr. Velasquez graduated from the University of Miami Miller School of Medicine, and he trained in internal medicine and cardiovascular disease at the University of Texas at Houston, where he was also chief fellow. He then returned to Miami and Jackson Memorial for his fellowship in cardiac electrophysiology, and he will speak to us about a case in clinical electrophysiology. Without further ado, Dr. Laban.
Good afternoon, everyone. Thanks for the opportunity for allowing me this privilege to give you an update in hospital medicine. Let me share my screen. All right, I hope everyone can see that. Is that correct?
Yes.
Okay. All right, so once again, my name is Joshua Laban, recently appointed Assistant Professor of Clinical Medicine in the Division of Hospital Medicine. My task today is to provide you some updates in hospital medicine by reviewing some cases and discussing some of the literature that's been published in the past year. I have no relevant financial disclosures. My agenda today is to discuss updates in preoperative risk assessment, venous thromboembolism, and associated with cancer specifically, and the timing of endoscopy for acute GI bleeding. So let's begin with the first case. You're asked to pre-op a 54-year-old man who's planning to undergo bariatric surgery to improve glucose metabolism. His past medical history includes coronary artery disease, hypertension, and diabetes type 2. He takes insulin, an ACE inhibitor, statin, and aspirin. He denies chest pain or shortness of breath, but has a sedentary lifestyle. His physical exam is normal except for he's obese. Labs showed creatinine of 2.1, glucose of 150, and his EKG is with normal sinus rhythm, except for non-specific T-wave changes. The question is, what is your next step? A, complete a subjective assessment. If meds are greater than 4, okay to proceed with surgery. Evaluate a activity status index. Get a pro-BNP, or refer to cardiology for stress tests. So before I move on to this study, a little background on this question is that there have been recent studies over the past couple of years on the utility of pro-BNP, and there's been data that shows that pro-BNP greater than 300 better risk stratifies patients with an elevated RCI score. For those of you that aren't familiar with the RCI score, it's the revised cardiac risk index score that we often use to assess patients preoperatively for post-operative complications. In this case, the patient had an RCI of 4, mainly because of his history of coronary artery disease, his use of insulin, and his creatinine above 2.1, so it warrants further assessment. There was a study completed earlier this year in 2020 that wanted to better evaluate the utility of pro-BNP in assessing patients. Previously, studies have shown that pro-BNP has utility, but it's mainly been these studies that have evaluated the prognostic capability of pro-BNP. They've used a predetermined dichotomized pro-BNP threshold, mainly above 300. So this cohort had a much larger sample size, allowing for greater statistical power to identify several pro-BNP thresholds that demonstrated improved risk prediction when added to the RCRI. So the research question that they pose, does pro-BNP have additional predictive value beyond a clinical risk score, RCRI, for composite of vascular death and myocardial injury after non-cardiac surgery, which I'll refer to as MINS going forward, within 30 days after surgery. So this most recent study was a sub-study of a larger cohort study, the VISION trial, a Canadian study that enrolled adults aged 45 and older who had inpatient non-cardiac surgery with regional or general anesthesia. The original study had more than 18,000 patients, and the sub-study included patients with prospectively collected preoperative proBNP measurements. More than 10,000 patients were enrolled. Healthcare providers were blinded, as well as the study personnel, to the proBNP measurements. Troponin T was measured postoperatively at 6 hours in days 1, 2, and 3. Patients that had a troponin T elevation more than 99th percentile were evaluated for further ischemic changes and had an EKG done. Research staff then contacted patients 30 days after surgery to determine whether any of the outcomes had occurred. Table 1 mainly shows the baseline characteristics of the patient. The mean age was 65 years, 50% were men, 20% of the patients had diabetes, 14% of the patients had coronary artery disease, quite common in the patients that we treat. The most common surgeries were major orthopedic surgery, 25%, and major general surgery was about 18%. I highlighted this box on the top to show the thresholds that the researchers identified as significant. This slide shows the cost proportional hazard models used in the comparison. They used a reference group in the first column, those patients with proBNP less than 100, to compare with the other values in the patients in the thresholds between 100 to 200, 200 to 1500, and greater than 1500. So in the first cohort, those with the proBNP 100 to 200, they saw that there was an adjusted hazard ratio of 2.27. Then the second group, the adjusted hazard ratio was 3.63. And those with the proBNP greater than 1500, their adjusted hazard ratio was greater than 5.82. Notice that the confidence intervals did not overlap, which is a significant finding. Table 3 is a little bit difficult to interpret if you're not familiar with the statistics behind this, specifically the net absolute risk, net absolute reclassification index. This table shows the reclassification of patients who had and did not have the primary composite outcome according to the predicted risk using the RCRI and the RCRI plus and BNP thresholds. The percentage of reclassification showed improved risk prediction. That is, patients were classified in more appropriate risk categories when n-proBNP values were included for patients with and without events. So in conclusion, these researchers were able to show that preoperative proBNP is strongly associated with vascular death in men within 30 days after non-cardiac surgery and improved cardiac risk functions by identifying thresholds that we can hopefully use to better risk stratify patients in the future. The next step would be to incorporate these statistics into online risk categories that physicians and frontline practitioners can use to better assess patients perioperatively. Some of the strengths of this study were that the healthcare providers were blinded to the n-proP measurements and therefore could not act on the results and potentially alter the relationship between the proBNP and primary and secondary outcomes. Some of the limitations, however, were that the required preoperative blood sample drawn for proBNP prevented enrollment of some patients having urgent or emergency surgeries. However, this may not be a limitation of the study. The utility for preoperative risk stratification may be greatest in the context of elective surgeries. Urgent emergency surgeries are generally done for organ or life-threatening conditions, and avoiding delays generally outweighs concerns for preoperative cardiac risk stratification. Other limitations that critics have pointed out is that proBNP measurements in obese individuals tend to be lower, so additional subgroup analysis should be conducted. So let's move on to the second case. You admitted a 61-year-old woman with metastatic breast cancer with intractable back pain due to lumbar metastasis. She started on radiation therapy while hospitalized, but develops a hospital-acquired DVT in the right lower extremity before discharge. She has already received 5 days of low molecular weight heparin during her care in the hospital, standard of care. For treatment of her DVT, she refuses to inject herself with low molecular weight heparin shots. What do you prescribe that is non-inferior to heparin? These are your choices: Oxaban, Dapigatran, dose-adjusted warfarin, Apixaban, or aspirin. So a little background on this. There was 2 trials published within the past 2 years, the Cassini and the Avert trial, that showed that rivaroxaban 10 milligrams during the intention to treat analysis did not reduce VTE events versus placebo, but did so during the intervention period of 4.3 months on average. Rivaroxaban did have a lower rate of bleeding. They also saw that apixaban did reduce VTE events. However, apixaban was associated with higher rates of bleeding. So here comes. So this study that I'm going to introduce next wanted to identify if apixaban truly was associated with increased risk of bleeding. This is the research question that they posed. Is oral apixaban non-inferior to low molecular weight warfarin with prevention of recurrent venous thromboembolism? And is it associated with increased risk of major bleeding? This paper was published in JAMA in 2020. Apixaban for the treatment of VTE associated with cancer. This slide highlights the study design. It was a large multinational randomized controlled trial, which looked to answer the question that I already discussed, comparing apixaban to a low molecular heparin. They used dactiterin in this trial. As I mentioned, therapeutic doses of low molecular heparin were allowed for a maximum of 72 hours before randomization. The apixaban cohort received 10 milligrams twice daily for 7 days and 5 milligrams twice daily for 6 months. The low molecular heparin cohort received dalteparin 200 units per kg daily for 1 month, then 150 units daily for 6 months. The outcomes, the primary efficacy outcome was preventing recurrent VTE, and the secondary safety outcome was identifying major bleeding. Again, I show the demographics here. The demographic and clinical characteristics of the patients were similar in the 2 treatment groups. Notably, patients had active cancer, about 97% of them, and were still receiving chemotherapy. I also wanted to point out that the ECOG score for most of these patients were between 0 and 2. So keep that in mind when applying to your patient population. ECOG scores with greater values imply greater disability. So the primary outcome of recurrent VTE occurred in about 5.6% of the patients in the apixaban group and 7.9% in the patients in the dalteparin group. The hazard ratio was 0.63. They showed a P of 0.001 for non-inferiority and a P of 0.9 for superiority. Major bleeding occurred in 22 patients in the apixaban group and 23 patients in the low molecular weight heparin group. Major GI bleeding occurred in 11 patients in the apixaban group and 10 patients in the dalteparin group. This slide shows the cumulative percentages of patients with recurrent venous thromboembolism, recurrent VTE in panel A, and major bleeding in panel B. As you can see, there was not a huge significant difference. The inset of each slide is just an expanded view with the y-axis highlighted. Now I just want to review some of the updated ASCO recommendations. There was an update in 2019 to the previous update in 2015 with these recommendations. Highlighted in the bottom box here in red is what I want to point out. It says that in patients with cancer and established VTE, initial anticoagulation may include low molecular weight heparin, fractionated heparin, fondaparinux, or rivaroxaban. after initial peritoneal low molecular weight heparin. Well, I just want to point out that low molecular weight heparin is still the standard of care and its preferred treatment. Of note, Pixaban was not included in this study, mainly because they didn't have enough research, and the previous trials showed that there's higher rates of bleeding with the Pixaban. So the bottom line is that the Pixaban may be included in the next update that ASCO puts out. A few take-home points. Currently, primary care providers and hospitalists are not likely to start these agents without consultation with oncologists. This may be expected to change over time. Additionally, some oncologists may be careful given the risk of bleeding, especially with GI cancers. Some oncologists may also want to target a better risk-benefit ratio before starting these agents. So the case continues. Your patient with metastatic breast cancer complicated by lower extremity DVT on a Pixaban presents to the ED with one episode of coffee ground emesis. The vital signs are shown here. The pulse was 85, the blood pressure was 110/70, respiratory rate 18, and oxygen saturation of 98%. On physical exam, there was melanoma present. Hemoglobin was 8.5, and the BUN was 35. What is the best next step? Transfuse packed red blood cells, delay endoscopy until a Pixaban is cleared, request endoscopy within 6 hours of GI consult, perform endoscopy within 24 hours of GI consult, or send the patient home with an oral PPI. Just a little background here. First, most physicians would probably not transfuse the patient with a hemoglobin 8.5. If we adopt a restrictive philosophy, we'd probably wait until the hemoglobin drops below 7 before we transfuse. And there was an international consensus group of gastroenterologists meeting to discuss the management of non-variceal upper gastrointestinal bleeding in 2019 that provided some guidelines. One of their statements were, in patients with acute upper GI bleed receiving anticoagulants, specifically vitamin K antagonists and DOACs, they suggested not delaying endoscopy with or without endoscopic hemostatic therapy. The grade of this evidence was a conditional recommendation, citing very low quality of evidence with no systematic reviews or randomized trials or observational studies that specifically address the timing of endoscopy as a primary outcome in patients receiving anticoagulants. This slide highlights the Glasgow-Blatchford scoring system, which helps identify which adults with upper GI bleedings report a higher risk. Often it's used in the emergency department to discharge patients who have lower scores. Typically, a score 0 likely does not need to be admitted for further workup. Of note, coffee ground emesis is not included as a tool, as it has as has been shown, it has low risk of case fatality, molecular ratio of 0.5. This article was published in JAMA in April 2020, timing of endoscopy for acute upper gastrointestinal bleeding. Background. As I mentioned earlier, the current guideline is that upper endoscopy is to perform within 24 hours after gastroenterological consultation to manage upper GI bleeding. This slide was provided by Dr. Deshpande, which highlights some of the previous studies that the international consensus group probably reviewed in issuing their statement. It shows that these randomized controlled trials and cohort studies had insufficient evidence to show early endoscopy could reduce rebleeding, need of surgery, and mortality. Caveats that he pointed out were that these studies were for patients with non-variceal upper GI bleeding. And of course, the whole goal of this is to reduce costs by decreasing the length of stay within the hospital. So the research question that they posed was, does urgent endoscopy less than 6 hours of GI consult improve outcomes in patients predicted to be at high risk for further bleeding or death in acute GI bleeding? This was a Hong Kong study that included 516 patients randomly divided into 2 treatment groups. The inclusion criteria is listed here. They had to have overt signs of acute GI bleeding and a Blatchford score of greater than 12. The patient that I described earlier had a Blatchford score of 13. The intervention in the urgent group was an EGD in less than 6 hours after GI consult. In the early endoscopy group, EGD was between 6 and 24 hours after GI consult. And the endpoints were death from any cause within 30 days after randomization. Again, I show the baseline characteristics of the patients. Of note, most of these patients were identified to have higher risk of bleeding complications with Glasgow scores greater than 12. Also, I wanted to point out on the bottom of the slide, the endoscopy findings. Most of the patients, 61% roughly in each group, had peptic ulcers as a source of bleeding. About 9% of the patients had esophagogastric varices in the urgent endoscopy group and 7.3% in the early endoscopy group. Table 2 shows the timing of endoscopy. Now, the mean time from presentation to endoscopy was 9.9 hours in the urgent endoscopy group and 24 hours in the early endoscopy group. I also would like to point out on the bottom of the timing of endoscopy. Endoscopy was performed between 6 p.m. and 5:59 a.m. in 96 of the 255 patients, about 36% of the patients in the urgent endoscopy group, and about 6.7% in the early endoscopy group. Post hoc analysis showed that the percentage of patients with further bleeding and the percentage of patients who died did not differ significantly according to the time of day of endoscopy. The significance of this is that this data should be only extrapolated in settings where GI consultation and endoscopy is available 24 hours, like here in our campus. This slide here shows Kaplan-Meier estimates of the cumulative incidence of death and further bleeding. Panel A shows the estimates of mortality during the 30 days after randomization, and panel B shows the estimates of incidence of further bleeding during the 30 days after randomization. Again, the inset of each panel just shows the same data on a large y-axis. So here shows our endpoints. All-cause mortality at 30 days after randomization did not differ significantly between the two groups. 8.9% of the patients in the urgent endoscopy group and 6.6% in the early endoscopy group died, with a hazard ratio of 1.35. Confidence interval showed non-significance between 0.72 to 2.54, the P is 0.34. I would note that the difference in mortality between the two groups was 2.3 percentage points. Deaths were mainly from gastrointestinal bleeding, deaths from gastrointestinal bleeding accounted for 5 of the 23 patients in the urgent endoscopy group and 2 of the 17 deaths in the early endoscopy group. Advanced cancer was present in 11 of 23 of the patients and 8 of the 17 patients who died respectively. I also highlight here on the bottom of the slide that many of these patients did receive red cell transfusions, roughly 90% in each group. And they show that their units of cells transfused was about 2, plus or minus 2. Don't exactly know how to interpret that. The patients were transfused. So conclusions to draw from this is that you can manage these patients before GI performs their endoscopy by monitoring the CBC Q8 hours, transfusing as necessary, and monitoring closely. Of course, if the patient deteriorates, call GI urgently, and they will be more than willing to help out. Otherwise, allow the GI fellows to get some rest if the patient is clinically stable. So take-home points. Pro-BN3 thresholds may be better to risk stratify patients in preoperative risk assessment when incorporated to the RCRI. Consider the use of apixaban for the treatment of VT-associated cancers. And urgent endoscopy probably means within 24 hours of GI consult. So please don't fret with your GI colleagues. Acknowledgements. I'd like to thank Dr. Efren Manarez in giving me some guidance in preparing these slides. This was a collaborative effort. And thank you to Dr. Deshpande for providing additional insights into the management of acute GI bleeding.
Thank you, Dr. Laban. That was very nice, very clear presentation of two very common problems that we see in the general medicine wards almost on a daily basis. If anyone has any questions for Josh, please either write them in the chat box or just simply unmute yourself and call out. I'll give people 30 seconds to unmute if they have any questions. Hearing none, we'll move to our next speaker, Dr. Velasquez, who was introduced by our chief resident, Dr. Rubin, at the beginning of the hour. And without any further ado, Dr. Velasquez.
Okay, well, thank you. Thank you for having me to discuss this case. All right, so I'm going to be talking today about premature ventricular complexes, the good, the bad, and the ugly. So I have no relevant disclosures. I'm going to start off with our case. So a couple months ago, I had a 74-year-old man who was referred to the emergency department for bradycardia from his pain management clinic. He was there for getting steroid injections for chronic back pain that he had. When he arrived in the ED, he had a heart rate of 35 beats per minute with sinus bradycardia, and occasionally he had intermittent second-degree Mobitz 1 AV block. His past medical history included hypertension, coronary artery disease, chronic lower back pain, and he had a remote history of a percutaneous coronary intervention, presumably a balloon angioplasty, because he did not recall ever having any stents. This was done in the 90s. His medications included metoprolol succinate, 25 milligrams daily. And this was his EKG once the metoprolol was discontinued and his heart rate improved. So he started having frequent premature ventricular complexes, as highlighted here. And the PVCs would often occur in ventricular bigeminy. When we reviewed his record, we saw that he had a Holter monitor 10 months prior to the presentation, which showed a burden of premature ventricular complexes of 28%. And then he was placed on metoprolol in response to that, and his follow-up Holter monitor 4 months after that, 6 months prior to our presentation, showed sinus bradycardia, second-degree AV block, Mobitz 1, and a PVC burden that decreased but remained elevated at 15%. So premature ventricular complexes are essentially just premature QRS complexes that originate from the ventricle, and they usually exceed the QRS duration usually exceeds the sinus rhythm QRS duration. Their mechanism underlying is usually triggered activity, but in post-infarct patients, you can have reentry be the mechanism of their occurrence. They're quite frequently found on routine Holter monitoring. Depending on the duration that you monitor the patients, you can find some form or some burden of PVCs in most patients. Hold on. Oh, yeah. So they're highly prevalent. However, when they're coupled with certain diseases such as ischemic heart disease, so in post-infarct patients, a higher burden is associated with a higher risk of death. Usually, premature ventricular complexes have nonspecific symptoms such as palpitations. You can have neck discomfort from ventricular contraction at the time of atrial contraction at the time of ventricular complex, which can cause Canon A waves. You can have angina. Few people will actually develop hypotension, and then it's often common to have symptoms of heart failure, such as shortness of breath. So in my patient, even though he presented from the pain clinic with sinus bradycardia and was relatively asymptomatic, once we discontinued the beta blocker, he identified that he had experienced irregular heart rhythm for years, and whenever he had the irregularity in his heart rhythm, he experienced shortness of breath and fatigue. So most patients will fall somewhere in this spectrum between asymptomatic and symptomatic, and having a high PVC burden or a low PVC burden. A majority of patients with PVC fall into this category, but anywhere on this side of the chart, you have to direct some form of treatment. So my patient had a high PVC burden and was symptomatic from the PVCs. And when I was examining the patient, one of the things that we identified was that just looking at his pulse oximetry as we were talking to him in the ICU where he was, we saw that the pulse oximetry, whenever he had a PVC, had a lower arterial waveform. The systolic pressure during the PVC was very low. Now, this is a demonstration of post-extrasystolic potentiation, which we expect after a PVC. But in the most extreme forms, depending on the origin of the ventricular complex and its timing relative to the native QRSs, you can actually have almost complete obliteration of the pulse during the PVC. So essentially, you have a mechanical bradycardia. So your electrical rate can be running at 60 to 80 beats per minute, but your effective pulse, peripheral pulse, is down in the 30s and 40s, and people will be symptomatic from that often. So what other consequences of PVCs can we encounter? So in patients who have a high burden of PVCs, we often find cardiomyopathy. The cardiomyopathy may be the cause of the PVCs, but in select patients, we actually identify that the high burden of PVCs actually results in cardiomyopathy. Now, part of the workup when we have a patient with PVCs, we have to identify if there's any non-ischemic causes or ischemic causes of cardiomyopathy that could lead to PVCs. But oftentimes when we're doing the workup, we can identify sarcoidosis, arrhythmogenic right ventricular dysplasia, and relative to today's times, post-viral, post-pericarditis, scarce substrate may also down the road lead to development of premature ventricular complexes and cardiomyopathy. A pre-existing cardiomyopathy may be worsened, so patient already had a systolic function down in the 30s and 40s, and when they start having PVCs, it may be identified to have a EF of 20%, which can be reversible if it is caused by the PVCs. In a select population, patients who have chronic systolic heart failure and have an indication for biventricular pacing to correct a interventricular dysynchrony. These patients require biventricular pacing as much as possible, and the goal is to pace the patient 100% of the time. However, due to their cardiomyopathy or intrinsic or due to their cardiomyopathy, they may develop PVCs, and as few as 8% can actually have clinical outcomes. They can have reductions in freedom from hospital heart failure, hospitalization, and death. So PVCs can interfere with the function of a biventricular pacer and reduce its efficacy in these patients. So, and then last of all, the most feared complication of a PVC, but it's albeit one of the rarest, is that you have PVCs that are malignant and can actually trigger ventricular arrhythmias, or polymorphic ventricular arrhythmias such as VF. This would be the most catastrophic, but it's also the least commonly identified. So how do we determine if a PVC is benign? So our initial evaluation should include whether or not the patients had syncope, if they've had a family history of cardiomyopathy or sudden death, electrolytes to see if there's any reversible electrolyte abnormalities, a 12-lead EKG to identify the origin or localize localize the origin of the PVCs, and then afterwards a Holter monitor to determine what the burden is. And an echocardiogram is an easy way to determine if there's existing cardiomyopathy on the initial evaluation. In this study, they looked at 518 patients with frequent PVCs greater than 1,000 per 24 hours, and who had relatively normal ECGs and normal echocardiograms. And what they identified was that certain risk factors on clinical characteristics such as male gender, age, family history of sudden cardiac death or cardiomyopathy, as well as unexplained syncope, those factors were associated with a higher chance of their composite endpoint of sudden cardiac death, resuscitated cardiac arrest, and non-fatal episodes of ventricular fibrillation that were appropriately treated by an implantable cardiodefibrillator. On EKG, the PVC morphology, if it was a non-left bundle inferior axis morphology, these patients were more likely to have malignant potential and cardiac events. And then lastly, they prospectively gathered MRI images, cardiac MRI images of all these patients, and they identified that those with gadolinium enhancement on the cardiac MRIs had higher chance of having the composite endpoint. So going forward, in the clinical evaluation of premature ventricular complexes, it's important to identify those risk factors which may target treatment and preventative therapies such as ICDs for those few patients that have malignant potential from the PVCs. Okay, so back to our patient. So we got an echocardiogram and his ejection fraction was 55%. We also did a cardiac MRI because since he had coronary artery disease and he had a coronary intervention, we suspected that maybe he had an infarct from remote history of an event. However, on the cardiac MRI, we didn't find any evidence of an old infarct. Especially, we focused our attention to the inferior wall where the PVCs, based on the surface EKG, looked like they were originating from. So what were the treatment options for him at that point? So antiarrhythmic therapy is the first-line therapy that's available to most clinicians. So beta blockers, calcium channel blockers, class 3 antiarrhythmics are his options. Class 1C agents can be used. However, in patient with prior coronary disease or ischemic disease, we want to stay away from those because it has an increased chance of sudden death. So the alternative is catheter ablation of the PVCs. So for catheter ablation of PVCs, we introduce a catheter through either the, or percutaneously through either the femoral vein or femoral artery, and we direct the catheter to the origin of the premature ventricular complexes. We localize it through electroanatomical mapping, and then when we find the location, we apply radiofrequency energy that can ablate the tissue that's responsible for it. So our goals are to alleviate symptoms, prevent deterioration of the LV function or dimensions, in some cases prevent sustained ventricular arrhythmias that may be triggered by the PVCs, and then patients with biventricular pacing improve the efficacy of the biventricular pacing. Catheter ablation is not without risk. In a large trial where they examined about 1,000 patients, they saw that the most common complication from catheter ablation is vascular. Pseudoaneurysm, hematoma, and arteriovenous fistula at the site of access were the most common complications. Cardiac complications such as cardiac perforation or tamponade or atrioventricular block were very infrequent, but they also occurred. And then, not listed here, not seen in this study, but anytime you're manipulating catheters in the heart, traveling from one chamber to the next, you can have valvular injury and acute valvular insufficiency. And then lastly, if you're working on the left-sided circulation, you can have thromboembolism if adequate anticoagulation is not implemented. So when we discussed these options with the patient, we discussed alternative medications. So he was already on a beta blocker, and we felt that any alternative antiarrhythmic would likely also produce this bradycardia, which you would refer to from the pain clinic. We could give him a floor with a permanent pacer, which would allow us to deliver higher doses of antiarrhythmics such as beta blockers or amiodarone. However, that would leave him with a prosthetic that he didn't have before, and that's lifelong and has its own associated complications. And then lastly, we offered him catheter ablation, which could eliminate the need for antiarrhythmics and thus avoiding a permanent implant. I conveyed to him that catheter ablation may not necessarily eliminate the need for a pacemaker, but it would be a way, a possibility, a way out of one. So before I present what we did, I just want to review a comparison of medical therapy to catheter ablation when it comes for the treatment of PVCs. And what we can see is that the most commonly used drugs in clinical practice for any type of arrhythmia, which are beta blockers and calcium channel blockers, for PVCs are not very effective. So in this study where they examined about 500 patients, about 200 of which were treated with medical therapy, and then another 200 which were treated with radiofrequency ablation. They saw that patients who were treated with beta blockers or calcium channel blockers were only able to reduce the PVC burden between 30 and 40%. However, class 3C agents such as amiodarone class 3 agents such as amiodarone and sotalol were able to reduce the PVC burden by somewhere between 70 and 84%. However, amiodarone and sotalol have their complications. Amiodarone in the long term can result in thyroid, liver, and lung toxicity, and sotalol, interacts with renal dysfunction and can become toxic if a person is to develop renal dysfunction. My patient actually had renal dysfunction a few months prior, acute renal dysfunction that spontaneously resolved. But should he have been on sotalol, his QT may have prolonged inappropriately. So catheter ablation, on the other hand, this study was very effective at reducing PVC burden. It reduced most patients by 93%. This is not a randomized controlled trial, and so safety and efficacy can't be concluded completely, but it does show that radiofrequency ablation can be effective. In these trials that they look at the efficacy of radiofrequency ablation for catheter ablation for PVCs, they often look also at the ejection fraction and its response to catheter ablation. And they saw that most patients who had cardiomyopathy at the time of the catheter ablation had some improvement of their ejection fraction post-ablation. And this was not observed in the patients with antiarrhythmic therapy. So are all PVCs equal candidates for ablation? And for the most part, the most success is found with patients who have ventricular outflow tract PVCs, either in the right ventricular outflow tract or the left ventricular outflow tract, described here as the cusp. If the PVC is of non-outflow tract origin, such as from a papillary muscle or an epicardial origin, the chances of success are lower, but they're not zero. They're still worth attempting. Patients who have multiple PVC origins may have more extensive myocardial substrate, and so their chances of recurrence is likely higher because of that, and so their success rate are generally lower. So in our patient, he chose the ablative route as a chance to avoid a pacemaker, and what we did was we mapped the left ventricle where we were likely to find the origin of PVC based on the surface EKG, and we localized it to the base of the infroseptal left ventricle near the mitral valve. So even though we found the earliest signals in this region and we applied several ablation lesions to this region, we were only able to suppress the premature ventricular complexes without ablation. So that's when within the case, we re-examined our approach. And so here's an alternative viewpoint. So here, this is a parallel anatomically of what we're seeing on this side of the screen. So here you can see that this void is representing the atrioventricular groove seen here, and this is like a lateral view of the left ventricle, and this area is basically the basal ventricle near the mitral valve, and you can see that a series of ablative lesions were performed here without suppression of the PVCs, and so that's when we redirected our attention to the coronary sinus, which, even though it didn't have signals that suggested that that's where the PVC was originating from, this tissue in between is likely where the source was. However, endocardial energy was not sufficient to eliminate the PVCs within that region. And so by applying energy from the opposing tissue, from the opposing side, we were able to actually completely eliminate the PVC. It went down to zero with basically 2 adjunct lesions. So more importantly, how did the patient do? So a 24-hour Holter done 10 days post-operatively showed predominant sinus rhythm, no significant ventricular arrhythmias. He did have occasional premature ventricular complexes, but they were not of the same morphology as the original one. And then additionally, we noted that he continued to have bradycardia despite the ablation, despite having discontinued his beta blocker. He continued to have AV block, the 2nd degree AV block. So the medications were not the sole reason for the initial presentation. But clinically, he reported a significant improvement in his symptoms. So he went from having a high PVC burden with symptoms down to no symptoms and no PVCs. Due to the high degree AV block, and we chose to pursue a pacemaker, so we placed a dual chamber pacemaker, and to preserve his ventricular synchrony, we placed a his bundle pacer to capture the native conduction and preserve ventricular synchrony. So at the end, this is his EKG post-operatively after the pacemaker was implanted. Here you can see that the QRS remains narrow because we're capturing the native conduction. So take-home points for this patient, for this case, are that PVCs, when symptomatic, are associated with cardiomyopathy, and when symptomatic or associated with cardiomyopathy require treatment. Medical therapy can be implemented early on, but is less effective than catheter ablation generally. And evaluation of underlying substrate to assess malignant potential of the PVCs is recommended. And I'd like to thank everyone for letting me speak.
Alex, thank you very much for that beautiful presentation. I really liked the juxtaposition of the Dr. Netter's drawings from the 1950s to your Star Wars pictures of catheter ablation. There was quite a contrast and quite interesting to show where the roots are. I guess one question that might be asked is, in general, for the evaluation of PVCs, at what point is a role of, does one look at the role of ischemia as a cause, and is that early on ruled out or not?
Yeah, so early on, so the divergence actually occurs at the point of an echocardiogram. So echocardiogram is one of the first things that can easily identify patients with cardiomyopathy and potential ischemic disease. So any patient who you're evaluating with high burden of PVCs and is identified to have cardiomyopathy by echocardiography, that person should have some kind of ischemic evaluation as well, because you know, in this country, ischemic disease is of high prevalence, and you know, before pursuing cardiac MR, should have some kind of evaluation, especially if there's cardiomyopathy. Now, if a patient's ejection fraction is normal, then an ischemic evaluation may be reserved for later. But with any symptoms of chest pain or angina-like symptoms, I would not withhold an ischemic evaluation early on. I think it's important because oftentimes it does play a role.
Thank you. Anybody else with questions or comments for our speaker? Well, I thank both Doctors Velasquez and Laban for a very nice grand rounds to begin the year, and we look forward to seeing everybody next week. Have a pleasant and safe day.
And just quickly, for those that weren't here at the beginning, if the CME tracker is still down, so don't click to claim credit now, but you'll get an email once it's up so you can claim your CME and MOC credit. Thanks very much.